First of all, I want to thank you all. I feel so overwhelmed, but also I felt like I learned a lot just between yesterday and today that I haven't learned in the past 2 years since Hannah was diagnosed with epilepsy. I also love the confirmation I heard from the panel earlier that she was a high risk because she was diagnosed just recently, but unfortunately, I wasn't given all the tools that I needed to fight with her or beside her. Being here today is something I never actually pictured or imagined. It's just something that happened and pushed me to be part of this community. Hannah is bright, kind. She was simple, very simple, strong-willed, determined, and full of laughter that could light up a room. I can't speak about Hannah in the past yet. I cannot say she was, because she is, and she will always be. I just lost Hannah recently, so it's been only a little bit over 7 months. So it's still raw. My grief is still like all over the place. I don't know even how I'm gonna react while I'm working or talking right now, so I really appreciate your patience. When Hannah was a child, actually from the first day she was born, I will go from there. I don't know if I have a clicker. Yeah, that's fine. She was special from day one. She was born on March 6, 2006 at 6:06. How special is that? She was a healthy baby. Unfortunately, I didn't get to hold her the first day because I had an emergency and I didn't know that I was gonna make it, but I did. And Hannah decided, because during labor, she decided to turn sideways, just how she was, very special. Hannah disliked milk from day one, and she was a baby. So we struggled to feed her or even give her something to get through the day and the next day. Hannah slept through the night. It was no issues. I didn't have all those, I always tell her, you teased me, and I had other 2 boys after, and I learned my hard lesson. But she had different shoe size also. Her feet were not the same size. And she was the perfect baby for a young mother with no experience or family support. During her toddler years, and I don't have a lot of information in there, but I always saw that Hannah was different. She didn't talk from the normal milestones that the toddlers will have. I always question her pediatrician, but she's like, it was 2006, people didn't know much about autism, so I didn't know about autism then, but I had to fight really to get her diagnosed at the age of 11. She was struggling in school, in elementary school, but then after that diagnosis, that took a lot of work. I was able to get her an IEP, and from there, that's where my advocacy actually started. So after getting her the IEP, she became so successful. She had a very bright mind and way of thinking of things. She had a math learning disability that no one could have figured out. We saw 3 different psychologists. We did all the testing. We saw neurologists. No one could have pinpointed because she can do algebra and she can do pre-calculus, but she cannot solve word problems, like simple ones. So that's how I joined actually the learning disability. But she ended up graduating from high school in 2024, and she graduated with a GPA over 4.0. Then with all this, she was diagnosed with epilepsy. Her first seizure was in February 2023. It happened in school. I was called, went to the hospital, did everything, was sent home. Something inside me said something is not right. I was sleeping with her in her room, making sure she doesn't have a seizure that I'm not aware of, until we saw a neurologist, and that took about 2 months. She didn't have any seizure during that time. We did all the testing, EEGs, MRIs, we did genetic testing, but they saw some seizure activity in her EEG, so they put her on medication. She didn't have any seizure that I know of until June 2024. And that was the day after her graduation. We were at the beach. We lived in Virginia Beach at the time. She was swimming, and I was sitting, and I would never let her swim by herself. She was surrounded by friends and her brothers, and then I can see her struggling, and they were trying to pull her. So I was rushing. The lifeguard was there, but didn't move a finger for some reason. So I was yelling, I was screaming, she's having a seizure. So we pulled her out, took her to the hospital again, and I was so thankful she made it, and she was fine. She headed to college in August. Her neurologist was very reassuring. She said, let her live her life, be a normal child. I knew about other risks, but the word SUDEP never came up until I lost my Hannah. I never heard it, never knew what it was. I wish I did. I know I heard here, I may not stop her death. That's absolutely, I believe on that too. But at least I will believe that I did everything I could, because now I live with the guilt that that information was withheld from me, and that I wasn't able to take all the precaution that I was supposed to do as a mother, as a protector, that I protected her whole life. I fought for her whole life, and then they failed me at the end. And I'm not here against any professionals here. I love you guys. I love the work you're doing. I'm just, as a mother, I'm expressing my frustrations and probably the frustration of so many mothers that I talked to since yesterday. So Hannah was also a creative writer, and her last piece of writing was Another Place, Another Time. If anyone is interested, you can read it. But for me, this one, when I found it, she was almost explaining what's going to happen, which is weird. I don't know. But she said that she has a purpose, and she has a purpose somewhere else, and she's going to find that purpose. So what keeps me going is thinking that she has a purpose up there, and that's why she's there, and my purpose is here for now to fight for other families and other children and be the voice for other families so they don't have to deal with the pain that I'm feeling. So I live now to be like my Hannah. There are a few things I hope you will carry with you today, not from a place of blame, but a place of partnership and possibility. Please talk about SUDEP. Please. I don't know. I know we are all here working, figuring out how we're going to do that. Support families in understanding the risks, all the risks, especially for teenagers, because teenagers need to hear it from you guys. They don't need it to hear it from mom. Take your meds. Did you take your meds? Did you get 8 hours sleep? They don't want to hear that from us, but if they hear it from you, I'm pretty sure they will follow it to the T. Treat families as a true team member. I know we're not doctors. We don't have medical degrees, but we know our children. We know them. And I know we also said about advocacy, parents should start. I cannot start a conversation if I don't have the information. That's the problem. So if I'm never given the information, there's no way for me to think about what type of questions I can ask. I can do that with autism. I can do that with type 1. I have a son with type 1. I can do that with ADHD. I can do that with learning disabilities, but I couldn't do it with epilepsy. Continue supporting research and bring on innovative ways that you guys are all working on. Finally, I don't share this to open wounds, or I share it because stories have the power to change practice. Our kids are more than just a medical record number. They are real. They were here, they had a life, and they lost it. Hannah's story matters. Your work matters as well. And somewhere out there, there is a family who will never know our heartbreak because a medical professional in this room choose to have a conversation that used to feel so hard. So we're trying to make it easy so you guys, hopefully, we will have this conversation openly without any fear. My hope today is simple, that by learning from our loss, we can protect someone else's tomorrow. Thank you. I forgot to click. Sorry.
Thank you, Safaa, for sharing Hannah's story and for being here today with us. We're fortunate to have 2 speakers for our next talk. We're going to provide an update from the International League Against Epilepsy. Our first speaker is Lisa Bateman. Dr. Lisa Bateman is a professor of neurology and the director of the Cedars-Sinai Health System and the Surgical Epilepsy Program. Her research focuses on identifying mechanisms and biomarkers for epilepsy-related mortality, particularly sudden unexpected death in epilepsy. She is a member of the planning committee for the PAME conference and has served on the International League Against Epilepsy SUDEP Task Force, the American Epilepsy Society SUDEP Task Force, and advisory boards for the North American SUDEP Registry, the Sudden Death in Young Registry, and epilepsy associations in both Canada and the United States. And our second speaker is Dr. Elizabeth Donner, who is the head of neurology and the co-lead of the Gary Hurwitz Center for Brain and Mental Health at the Hospital for Sick Children, Bloorview's Children's Hospital Chair in Pediatric Neuroscience and Professor of Pediatrics at the University of Toronto. Her clinical work is focused on the medical, dietary, and surgical treatments of drug-resistant epilepsy, and she leads the research program focused on identifying risk factors for sudden unexpected death in epilepsy. She has a strong commitment to epilepsy advocacy in the professional and lay communities. She's a member of the International League Against Epilepsy Mortality Prevention Task Force, part of the leadership team for Partners Against Mortality and Epilepsy, and lead of ECHO Ontario Epilepsy Across the Lifespan. So it's our pleasure to have both Dr. Bateman and Dr. Donner today to speak about their work with the International League Against Epilepsy SUDEP Task Force.
Thank you for that kind introduction and for giving me the opportunity to speak. And for those of you who heard me before, I'm going to try not to put my foot in my mouth this time. So part of what the theme of this session was, uniting for impact and the importance of collaborations. And certainly the ILAE SUDEP Task Force is one of collaboration. But I want to do a little bit of a walk through the history of collaborations in the SUDEP space, and then Dr. Donner is going to talk more specifically about the task force itself. So, brief history of our collaborations. So, I think around about 2007, many people in this room, not me, I'm not on here, I was too baby then, but the American Epilepsy Society, the AES, found a first SUDEP task force. And if you look at the list of the names, those are people who are academicians, clinicians, but also advocates and bereaved individuals. Got together to form this task force to set up some guidance and some recommendations for SUDEP, both research, education, and advocacy. And so some of the key recommendations that came out of this that I'm just going to highlight. One was that, hey, there needs to be a multidisciplinary conference held on SUDEP research. We need to talk about how we involve patients and families in SUDEP education. We need some kind of advocacy platform, and we also need to have families and patients involved in epilepsy research and particularly research surrounding risk assessment and prevention. As you've heard from some other speakers, there are issues with autopsies and how we define deaths in individuals with epilepsy. So there was a call to mount an autopsy campaign and to work with the community, including medical examiners and coroners, on this. There was a call for funding to research both clinical and basic science aspects of SUDEP, including things related to defining risk factors, the mechanisms, why does SUDEP actually happen and how does it happen, and then what can we do to prevent it. Again, criteria for how we define the death and perform the autopsy. And then finally to facilitate research both for large consortia, because when you're studying something like death in epilepsy, you need large populations. This is not something you're going to solve by one study at one center, but also for individuals to look into specific aspects of SUDEP. So one of the things, big recommendation, we need to have a multidisciplinary consortium to talk about SUDEP research. So year or so later, there was this workshop held with the NIH, NINDS, so the National Institutes of Health, and specifically the National Institute of Neurological Disease and Stroke workshop on sudden death and epilepsy. You see some familiar names on there. And again, things that were discussed at this meeting were talking about research agenda, how we create some multi-center studies to examine some of these aspects of SUDEP. We should have some kind of a SUDEP registry. So how do we get information learn something from the unfortunate circumstances of someone who died from SUDEP? Promoting education for patients and families, but also for healthcare providers and bringing those people together. Maybe we should develop some kind of SUDEP practice guideline. And then as well, talk about some ongoing SUDEP work groups. Well, one of the things that came out of all of this was the very room you're sitting into today, PAME. So uniting providers, researchers, patients, families, advocates, and other involved individuals to address now not only SUDEP, but other issues of mortality and epilepsy. Similar time frame, this other program was developing, and it's been mentioned earlier as well, the Sudden Unexpected Infant Death and Sudden Death in the Young Registry, and on the right is just a little map of the centers that are involved. This is as of me pulling it off the internet yesterday. I don't know if there's more or less, but usually some people involved with that join us here. And I can say that in this registry, neurological causes of death, particularly SUDEP, are included, and I know this because I was on the committee for this, as was Dr. Tan, who talked about earlier to start off the meeting. We also got that practice guideline that was recommended. And this was a combined guideline from the American Academy of Neurology, the American Epilepsy Society, as well as pediatric groups. And this is basically on how common SUDEP is and what are some of the risk factors. And the basic recommendations out of this are that patients and families should be informed. At the time, the rate was cited based on the evidence that was available a few years ago, that it was about 1 per 1,000 patient years for adults and 1 per 4,500 for children, and so we call these small and rare risks. And of course, anyone who's been that one knows it's not small or rare. And we also now know from more recent research that children's risk is actually probably similar to adults. There should also be encouragement of active management of the most significant seizure type, incorporating both patient preferences, but also weighing the risk and benefits of treatment changes, nocturnal supervision, which we're going to hear about a lot more, and that seizure freedom is strongly associated with reduced risk. There was also the creation of these two things, the North American SUDEP Registry, NASR, as well as this position paper combined with NASR plus Epilepsy Foundation plus the National Association of Medical Examiners and other people's on specifically autopsies in SUDEP and declaration of SUDEP deaths. And then when it comes to large research consortia, the Center for SUDEP Research is probably the most well-known that's come out of this. Our two fearless leaders on the top there. On the left is Dr. Sam Latu, and on the right, Dr. Jeff Nobles. A total of 15 centers participated in this project. These included both basic science and clinical researchers from across the United States and really around the world. And just to give you an idea, this is not a slide you're supposed to read, but this is just an example of how many research papers just in the last few years have come out of each one of those teeny tiny little lines is a paper that has come to advance our knowledge on SUDEP. And even now, these are two recent consortia, both on the North American level and the United Kingdom, on further work in SUDEP. So the conversation continues. We continue to work together to try to solve this issue. And I'll give it to Dr. Donner for the International League.
Thank you, Lisa. And I don't know that we've put it together that way before, and it actually does feel pretty rewarding to see that we actually, as a community, made recommendations and then followed up on those recommendations. And I hope it brings some some level of comfort to people who are still experiencing loss, that we at least have been trying to move towards making things better. And so I'm just going to very briefly let you know kind of what the International League Against Epilepsy has been doing with regards to mortality prevention. But before I do that, I want to tell you that the whole world, the international community, the World Health Organization is very interested in epilepsy. This is the PDF. You can get it online easily. Just Google that or IGAP epilepsy, and this will come up. And this is an action plan from the World Health Organization that was implemented in 2022. You can see through to 2031 with specific goals to address epilepsy and neurological disorders. And from the people that I have talked to who participated in crafting this and advocating this, what is so amazing is that it says epilepsy and other neurological disorders, really putting epilepsy at the forefront of neurological disorders. And what's amazing about that is if you go out there and say to like the general public, like, tell me a brain problem, they'll probably say dementia or stroke, right? The World Health Organization recognized that epilepsy has a tremendous burden around the world. Probably, I heard someone say there's 8 countries represented here. Is that right, Tom? Yeah. But including tremendous burden in countries that likely PAME is not reaching with this meeting today. And so this is really amazing. And I just wanted for you to be able to kind of quickly look at the vision of this, which is to really promote the need for brain health intervention and safety and quality of life for people who are suffering or have been diagnosed with epilepsy and brain disorders. So it's very, very powerful. And for those of you that haven't heard about the International League Against Epilepsy, the International League Against Epilepsy is an organization, and so for example, the AES is the US chapter of that. I'm from Canada. Robin and I are members of the Canadian League Against Epilepsy, and there's there's leagues all over the world. And really the mission of the ILAE is to ensure that everybody affected, health professions, patients and their care providers, governments, and the public worldwide have the educational and research resources that are essential in understanding, diagnosing, and treating people with epilepsy. It includes over 150 national chapters all around the world, and the vision is one in which no person's life is limited by epilepsy. And I think that's really important because I think it's important that we recognize we can't always cure epilepsy, even though we'd like to, but people with epilepsy should have the opportunity to have as full a life as they wish. And so I'm just going to tell you a little bit. I've been a member of the ILAE SUDEP task force, Lisa as well, which is why we're up here today. The most recent chair of the SUDEP task force for the International League Against Epilepsy is Rainer Sturgis. He wasn't able to be here, so we're happy to just give you a few words about this group and what we've been up to. So this task force started in 2021 with a 4-year mandate to identify priority areas in knowledge and practice related to SUDEP, promote multi-center research, improve understanding and knowledge among healthcare providers. And if you were in the last session, you heard me say the biggest barrier to not talking about SUDEP, to doctors not talking about SUDEP, is that they don't know enough about it. So I'd say number 3 is really important. And then promoting collaboration with stakeholders and organizations in related fields. And so some of the things that have come out of the work of the task force over the last 4 years are some medical practice tools. So in production, and I think our colleague Dan Friedman is sitting in the back, he's leading a project to develop educational videos to support SUDEP counseling. So through case vignettes, talking to experts about how they would talk to that person with epilepsy or that family affected by epilepsy. Also in production is a paper, a scholarly work that is addressing how we define SUDEP You heard earlier this morning a question about if you have a SUDEP, if a person dies in a motor vehicle accident because they had a seizure while driving, is that SUDEP? That's a really great question. It highlights that we need to partner with medical examiners, neurologists, healthcare providers, people living with epilepsy to really understand the best way to define it. Why is it important to define SUDEP? Because we can't study it if we can't collect the cases. And if we don't have a clear definition, we miss the cases. So that's very, very important. Right now, in the other breakout session, our colleague, who's also on the task force, Dr. Safaa Sharma, is presenting the results of a scoping review, which is like a detailed literature review around SUDEP counseling that she has led, that is going to roll into a project where we're developing an expert consensus guideline on SUDEP counseling. And I'll tell you the biggest difference between that project that is still to be completed and what we've done in the past is, before we used to ask the experts, who should we tell about SUDEP? Should we tell people about SUDEP? As a SUDEP task force, an international group, we are entering this project saying, we need to tell people about SUDEP. How should we do it? What tools do people need? What is the best way to approach that? And that's going to be a consensus document that, using a very specific kind of methodology called a Delphi process. But the important thing to know is that we are involving not just people who treat people with epilepsy, but also people with lived experience from all the regions of the International League Against Epilepsy. So representation from across the world. Also, part of the deliverables of our task force over the last 4 years, there was a virtual symposium and also webinars that were available for people, both kind of live and then, on demand, and all these things are on demand on the ILAE website. And then what's going to happen now that that task force has sunsetted, and don't take it as any kind of sign that the International League Against Epilepsy is no longer interested in mortality, that is sunsetted. In fact, the definition of a task force is that it's a time-limited committee, and so you get your deliverables, you do your work, and then you move on to your next task. And the next task is under activities, the Special Executive Mortality Prevention Task Force, and this is being led by Dr. Philippe Rivelin, who's also not here today. So again, Lisa and I get to stand up and talk about this, but and that broadens the scope from not just being about sudden unexpected death and epilepsy, but really broadens it to include all increased risk of mortality in people living with epilepsy. I think that's really, really important because there's intersections. And one of the things we've learned about how to think about SUDEP, or at least I should say I've learned over the last 20 years about how to think about SUDEP, is we often have to think about it in a greater context of epilepsy safety, how people can live and stay safe with their epilepsy, and talk about epilepsy safety. And so when we do that, we need to talk about things like the things we talked about this morning: driving, drowning, status epilepticus, mental health disorders, and suicide. And so that task force is just getting underway, but that will be our focus. And then very, very recently, I've just been asked to chair a task force focused specifically on pediatric SUDEP. And all I can say is that we will do some work, but I haven't yet identified my members or the deliverables. What really are some of the opportunities of this work that I think are very important is really the international representation. First of all, we need to ensure that we have the views and the perspective of low and middle income countries, which are often left out of these discussions, and really capture the experience across cultures. It's been very obvious to me that the way we talk about death and risk in Canada is different from the way they might talk about it in another country and in another cultural context, and we need to consider that. It also allows us to build collaboration across regions, and I can say even just personally, already my involvement in these task forces has allowed me to do that. And finally, I think moving forward for these activities, I want to see, and I know certainly in the group that I lead, an increased engagement of those with lived experience to ensure we're capturing the full spectrum of issues we need to attack. So I hope that my colleague Lisa and I have shown you a little bit about where we started and a little bit about where we're going, and this really sets us up for the next speakers.
Thank you, Dr. Donner. And just to remind, like with earlier, we'll do the Q&A at the end. So if you have any questions, you can feel free to jot them down on the paper, and we'll come around and collect those after all the speakers. Our next speaker is Laura Widener. As Chief Advocacy and Government Relations Officer, Laura leads and oversees the Epilepsy Foundation of America's strategy on federal and state level policy, legal advocacy, and grassroots engagement. The Foundation's advocacy initiatives seek to improve access to care, end epilepsy-related discrimination, foster research and innovation, and promote public health and education. Laura joined the Foundation in 2018 after 9 years focusing on federal access to care and disability rights policy and government relations for the National MS Society, and before that, 3 years with the Child Welfare League of America's Government Affairs team. Laura also serves in leadership positions of several advocacy coalitions, including the American Brain Coalition, Epilepsy's Action Network, Epilepsy Leadership Council, and the Partnership to Protect Coverage. So welcome, Laura.
Hi, everyone. I'm going to start a stopwatch because I have a lot of slides, and I promised Gardner and Allison I would not go over, so we're going to see how good my multitasking is. But thank you so much to PAME for having me here today. And I also just want to thank everyone in the room and everyone in the other breakout session. I've attended this conference for a few years now, and whether you're an advocate, a partner organization, a researcher, or a clinician, or anyone else, I have learned a lot from you, and it has helped me be a better advocate, as well as my organization, the Epilepsy Foundation, be a better advocate on all of your behalf. But I think, in this space and this challenge and this devastation, a lot of times it's like, well, what do we do, right? You want to turn the grief and the devastation into positive action for other families so that they do not have to feel a similar loss. And policy and advocacy is one way you can do that. So my goal here today is just kind of to give you a landscape of what's happening both at the state level and the federal level, but also acknowledge that I'm talking on behalf of a lot of you in the room who are doing this advocacy on the ground. So thank you for all your work with that. I'll start on the state level. This slide shows there are several states that have passed SUDEP or mortality-related legislation. They tend to take a few different, categories or different approaches. For instance, some have focused on medical examiner education. Others have looked at mandates when it comes to autopsies, how they're done, and what's reported from them. Awareness, which is obviously very important. Disclosure to patients. New York a few years ago put a law into place that physicians literally have to discuss SUDEP with their patients. Coverage, Medicaid seizure detection devices, I'll dig into that a little later, surveillance and registries. And then Oklahoma really wanted to blow it out of the water, and y'all tackled a lot of things. So Dillon's law just passed earlier this year, and it has a lot of components in it. There's a driver's license designation, medical examiner education requirement, awareness and autopsy mandate. So they're here if you want to talk to them about that effort. But with advocacy and policy, I've been doing this almost 20 years, and you really live and you learn, because, I can give you examples of federal, state legislation I've worked on for literally took 8 to 10 years to get across the finish line. You finally get it into law. You're like, everything's going to work and be better. And it doesn't always work. It can be well-intentioned. You can look at every word, every part of the bill. But when it's happening in reality, sometimes you're like, oh, wait, we didn't have an oversight mechanism or an enforcement mechanism. So PAME, one, celebrating all the work that's been done, but also always trying to improve and have laws in place that have even more impact, put together a legislative work group, and they met through 2024 and released a toolkit of state options that states could pursue if you want to pursue this type of legislation. So, and if you're at last year's PAME, I think we gave a sneak preview of that, but for those of you who weren't there, I'll do a high level here today. So some of the state solutions that, this group, which included advocates, epilepsy organizations, and some providers, thought would have the most impact. States could look at mandating their state health department to do certain things. For instance, develop standard information in conjunction with epilepsy organizations and stakeholders that could be provided to patients and families, and also healthcare providers in the state. They could be required to launch a state public health campaign, and or report all epilepsy-related deaths to a relevant SUDEP registry. When it comes to Medicaid, I think this topic's been brought up a few times already, but making sure that Medicaid in your state covers post-diagnosis epilepsy education and risk counseling, making sure that patients and families know from the get-go, have all the information, and can take precautions, do the best they can to prevent such tragedies. And the toolkit outlines a few possible ways that could be done through state Medicaid programs. You might know, but every state Medicaid's a little different, so we wanted to, again, give options for states to pursue. When it comes to death investigations, a few options here are requiring that death investigation professionals are aware of the latest recommendations. This could involve a training program. And then when it comes to the death investigation itself, inquiring whether death was a direct result of epilepsy or seizures, and if so, making sure that that's included in the report. So in 2025, we saw several states introduce SUDEP and mortality legislation. I'd say just in the past few years, there is increased interest and momentum, which I think is a great thing. So these two slides outline many, hopefully all, of the states that introduced this type of legislation. Some of them did pick up, solutions that were presented in the PAME toolkit, so that's great. And then I also wanted to put on your radar a very related state law. Minnesota, in case you're not aware, was the first state to pass a law that requires Medicaid to cover seizure detection devices. That was passed, I think, in 2023. The Epilepsy Foundation of Minnesota was at the helm of pushing for that and getting it across the finish line. And since they're one of our affiliates, we partnered with them to develop a toolkit, very similar to the PAME toolkit that was already in process for states, advocates, that want to pursue making sure seizure detection devices are covered in your state too. So the toolkit has, model bill language. It has various communication mechanisms that can help you in your advocacy, sample social media to raise awareness, a sample press release if you manage to get a bill introduced, kind of step-by-step instructions for how you even start the process of introducing a bill in your state. So this map is not completely exhaustive. It just shows a snapshot of, mostly we wanted to put on your radar some of the new states that we've learned. The past few months we've been checking with people on the ground in terms of where they want to start legislation. So again, that's the intention with this map. There's certainly other states that will be introducing legislation or, working on kind of a second round of legislation to increase what they have already gotten passed into law. And I think the biggest thing I want to mention when it comes to state level legislation is every state is different, right? What you might go to your legislative office and start talking to them about all of these options, and it'll vary state by state, like what legislators are interested in. So we really look at all of these as options. We wanted to give advocates a big menu to choose from, and whatever seems most viable in your state, whatever you're most passionate about, you can pick that up and pursue it. So switching over to the federal side, there are a few, SUDEP mortality-related things happening. The federal sudden unexpected infant death, sudden death in the young registry was mentioned earlier. But one of the newer endeavors that we wanted to make sure you're aware of is the National Plan for Epilepsy. So the National Plan for Epilepsy builds on, literally decades of groundwork that has been laid, looking back literally to the mid-'70s. Believe it or not, there was legislation in Congress to establish a National Commission on Epilepsy. There was obviously the 2012 IOM report. IGAP was just mentioned, which was great, which calls on countries to pass a national plan or have a national plan for epilepsy. So the community at large kind of has two very related efforts here. One, we want Congress to pass a bill that would authorize the National Plan for Epilepsy. And two, we're simultaneously working on drafting priorities for what could be included in a National Plan for Epilepsy. So getting Congress to pass the bill, again, a lot of groundwork laid here. I've been with EFA for 7 years now. We've always had a very strong advocacy government relations presence. I know some of your organizations have as well. But I would say, there hasn't been many initiatives where, all of the orgs work on this one thing. So I think there was a recognition in the past few years that we all need to work together more where we can and collaborate where we can, because by us all doing that, our voice will be louder and hopefully our impact bigger. So back in 2022, a group called the Epilepsies Action Network was launched with that intention. EFA is part of that, and some of you in the audience are part of that too. So really helped to build the momentum and think about the gaps, and decided that a national plan for epilepsy was really the best path to move forward. So the National Plan for Epilepsy Act, in the interim, we were also working on launching an epilepsy caucus in both the House and the Senate. We were successful in doing that. The House caucus launched first, and then the Senate caucus. On this slide here, you see all of our 4 caucus co-chairs, Senator Eric Schmidt of Missouri, Senator Amy Klobuchar of Minnesota, Representative Greg Murphy of North Carolina, and Representative Jim Costa of California. All of them have personal ties to epilepsy, which when you're working in the advocacy space, that's a really important thing to look out for, because those people, tend to be willing to step up. They get it, right? They're willing to step up and really be a leader for your cause. So we did manage to get the legislation introduced in November 2024 for the first time, and then with the new Congress starting in January, we had to get it reintroduced. We've seen great momentum the last few months. Last several months, we're over 40 co-sponsors in the House and about 11 in the Senate. So again, the bill would direct the Secretary of Health and Human Services to establish and maintain a national plan for epilepsy. The secretary would have to look at what's currently being done with epilepsy and start thinking about better ways to coordinate and improve what's happening in the government. It would also establish an advisory council made up of federal government representatives and non-government representatives, and they would be part of that process to come up with recommendations for what the government should do to improve the lives of people with epilepsy. Here, I just wanted to, the bill literally outlines focus areas that are really important to the community. And I just wanted to point out here that, preventing SUDEP and other epilepsy mortalities is literally listed in the bill, which was really important to all of us. We, learn from others. There are other disease states, including some neurological conditions that have already passed their plans. Alzheimer's is kind of the biggest one we know of, and it's the one that's been around for the longest in the neurological space. So here, just showing what an impact that has had. The government's investment in Alzheimer's back in 2013 was only about $500 million. In 2023, they've gotten up to $3.8 billion. So again, better coordination and obviously more investment is another goal of the plan. This slide, actually, we were just updating our org list. We're actually over 145 organizations at this point. So again, a really great unifying effort for the whole community. We do ask you, it's a very simple thing. If you scan this QR code, it should hopefully take you to a link where you can use what's called an action alert system. It's a kind of a pre-populated email. If you put in your zip code, it will tell you who your representative and senators are, and very quickly you can send an email to them asking them to co-sponsor the National Plan for Epilepsy. Drafting priorities for the plan. I'm getting tight on time. So here, again, we want to make sure that the community has been thoughtful about what we want to see in terms of improvements. So AES pulled a group together. EFA, several other orgs are part of that. Work groups were established, and over the last several months, they've been putting pen to paper and meeting a lot to come up with consensus priorities. It was put out for public comment. Hopefully you got that opportunity, and they've been updating that document, and it's up on the website. You can check it out. It's still waiting final approval, but it's in pretty good shape. So within that, there are 38 community priorities and recommendations. And on the next few slides, again, I just wanted to make you all know that SUDEP and epilepsy-related mortality was like a really important and consistent theme through that process. The topic is listed in, I think, 7 of the priorities, and on these slides outlines all the specific recommendations related to SUDEP and epilepsy-related mortality. And then here we have 2 of our long-term champions, Steny Hoyer and Tony Quello. Just quotes from them about how important it is for the community to work together, again, increasing our voice and hopefully increasing our impact. So we urge you to get involved in the national plan and the state level efforts, or both, whatever you feel most comfortable with. I'll just quickly wrap up with some challenges and suggestions if advocacy is new to you. So challenges, when you go to your Congress people or your members of the state legislature, they're hearing from every constituency you can think of, right? The biking community, oil, like everything you can possibly think of. So it takes a lot of persistence and really strengthening your relationship with them to make sure that epilepsy is risen on their priority list. Another challenge we've experienced, particularly at the state level, is it's like one of those good problems to have. People get very passionate and they want to get bills introduced, and sometimes in one state, we've had 2 or 3 pretty related bills, introduced, and that can be challenging because it can be a little confusing to the legislature. Well, they want the community to work together, and if we can all go to them with like one bill and all be behind it, that can really help with your effectiveness. And then budget situation, both at the federal and the state level, has been really challenging. Strategies, just to close this out, I mentioned earlier finding legislative champions with personal connections to epilepsy, doing pre-work to avoid expected challenges or oppositions. Think of the stakeholders your legislation would impact, for example, the medical examiners. They're powerful in the state, right? So maybe reaching out to them proactively and talking through what you're thinking about and trying to come to consensus with them as you work on your legislation. Lean on organizations and other advocates to support you. I listed 2 here, Allison Kukla, obviously with PAME, and Dominique with EFAs over there in the fabulous red suit. Raise your hand. You are not alone. There are a lot of people and other advocates who've been down these roads and can help advise you as you go, building coalitions and focusing on data and personal stories to make your case. And I'll just leave you with I truly, truly believe this. Anyone can and should be an advocate. It can be scary. You're like, I don't understand the government, or I hate the government even, but you really do have the power, and your personal stories are what have the impact. I've been in countless meetings. I can give the stats, but when the person with lived experience, shares their story, that's when the staff or the members' eyes and ears really open up. So thank you for the time. Sorry, I went a little over.
Thank you, Laura. And just a quick comment to say, 10 years ago, we did not have this much momentum in the legislative activity. So it's a credit to Laura and her team, Dominique, and several people in this room. So very exciting time for public policy in epilepsy. Our next speaker is Dr. Laura Lubbers, who is the Chief Scientific Officer at Cure Epilepsy, and is responsible for developing and executing the organization's research strategy and all research programs that seek to cure epilepsy, not just treat the symptoms. Importantly, Dr. Lubbers' sister, Ellen, suffered from intractable epilepsy from an early age, and her mother was diagnosed later in life. The impact of epilepsy on her family fuels her passion to find better healthcare solutions for people with epilepsy. Dr. Lubbers holds a Bachelor of Science in Physiology, as well as a Master's and PhD from the University of Illinois, Urbana. So welcome, Dr. Lubbers.
Great. Thank you. Thank you, Tom. It's great to be here. I have been asked to give this talk because our dear colleague, Vicki Whittemore, was unable to travel to the meeting this year. But I hope to share similar thoughts to what she would be sharing with you because we are both very aligned on this topic. Some of you may have already heard aspects of this talk, and some of you in the room might have actually participated in this project, but this topic might be new to many of you. Regardless, I think it's always worth repeating in the same theme of the earlier talks around unity, around having shared language, around collaboration to truly drive change, which is what we really want to happen fast for SUDEP, to really come to understand the mechanisms that lead, the biological mechanisms that lead to SUDEP, as well as preventative strategies for this terrible occurrence. This project was actually born out of another collaborative project, specifically the SUDEP Summit that was hosted by the Epilepsy Foundation in 2020. It's already been mentioned in an earlier talk. The results of that summit were published just this year. That event brought together many different stakeholders. It brought together researchers and clinicians and people with lived experience to help identify priorities that would move the topic of SUDEP research and prevention faster, and awareness. There was a working group of basic researchers who got together and identified a number of priorities, including the desire to have standardized reporting for SUDEP, models and methodologies. They wanted to be able to align basic SUDEP research with the clinical experience. Aspirationally, they hoped for a data depository with research and clinical information that would be searchable, ever evolving, and help them understand what the newest findings were and where the field needs to go next. To be successful with this, however, it's essential to have a shared language that the research community can rely on. For those who don't live in the lab, who are in the audience today, it's important to understand that most labs are evolving their methodologies. They may measure an endpoint differently from the neighboring lab. They might call that the same thing, but perhaps it's not. They may use the same terminology for different endpoints. So you can imagine that this could lead to confusion. So that's why, I mean, this is very similar to having different dialects of a language, where the same word used in Australia, for example, might be different, may have a different context in the United States. So we really have to come together as a community to avoid the confusion and make sure that the research and the results that are produced actually are able to be compared and be translated to the human condition. So Cure Epilepsy set about trying to fill this gap in language by bringing together a group of steering committee members, some of whom are in the room today, as well as working group members who are also here today, to talk about what are the key features of a SUDEP study. What do we need to do to really define those clearly for researchers? So we brought people together that had both the basic research expertise as well as the clinical expertise, because we wanted to make sure that whatever was produced would be relevant to the human condition. Let's see if I can get this to move forward. There we go. So in the process of discussion, we identified over 100 common data elements. That's the key here, common data elements that were defined that were related to SUDEP research. We assembled those into what are called case report forms. And an example of that is in the center of the slide. I don't have a pointer, but hopefully you can see that. And it essentially looks a lot like a laboratory notebook that identifies what are those key elements of the research study that need to be recorded and then communicated. There was a key module that is focused on the actual occurrence of death in these research studies, but we also identified multiple common data elements that were related to other aspects of physiology, for example, respiration or cardiac function, as well as interventions, and put those into case report forms that researchers can use. This is really intended to help researchers communicate what they're doing. And they can choose to use the forms that are appropriate for their studies. As is true for every language, it's really helpful to have a dictionary of terms. So in addition to identifying the common data elements and putting together these case report forms, we also developed data dictionaries. So these dictionaries help the researcher clearly define the data that are being collected in their study, so that others can clearly understand what they did. It seems simple. It's not simple, and I appreciate that, but it's a step to take. This allows other researchers to more closely replicate study conditions and collaborate and compare their results. When anyone is learning a new language, it's really important to study and practice that language. So 2 publications are now available online. They were published this year that describe the development and the utilization of these SUDEP CDEs. So this is how you go about learning about these. And then, of course, we hope people will practice using them. Researchers can also go to the ever-expanding list of common data elements that are listed on the NINDS Common Data Elements website. Yes, there's actually a website dedicated to this, because it's a real It's a growing area of appreciation in the epilepsy community. There are many different common data elements that are being developed to tackle different kinds of epilepsy research. So what we are encouraging people to do is use these tools. It's really critical for researchers to be able to describe their data to not just each other, but as we have learned this year, I think, to the broader general community, but as also to funders. So as a funder, it's important for us, at Cure Epilepsy, to ensure that the data that are generated, often with very precious donor dollars, are as widely used as possible. This is why we are strongly encouraging researchers to use common data elements in their work and refer to them in their grant applications, and it's certainly a consideration when funding choices are being made. Finally, it's really important to report the methods that are used in research studies in publications. And it's essential to, we hope that people will be able to use these common data elements and report those in their publications. We've got some early adopters who are doing that. This publication was from the lab of Christina Simeone, where she's nicely calling out the use of common data elements. So again, we really need to come together. This is the theme of this session: unity, coming together, sharing, collaborating. There is a long tradition of researchers holding their data tight. I understand that. They spend a lot of time and energy developing their research studies, generating the data. Often, and researchers in the room will agree, science doesn't work the way we want it to. And so when you get good results, it's really exciting. And there's also a lot of competition. And in sharing your secret sauce, sometimes people worry that they're going to get scooped. And I hear that. But again, it is finding ways to work together. That is really, at the end of the day, the important point of all of the work we're doing is to save lives, is to understand the causes of SUDEP and figure out how to translate that to preventive strategies. That's really what our goal is here. So we hope that these tools will enable research collaboration by increasing transparency of methods and data, enabling the research community to compare SUDEP data. We hope that it will help align data across preclinical research studies, allowing researchers to combine data more effectively. We know that SUDEP is rare in the clinical community as well as in the preclinical community. That's why we need to be able to combine data sets in order to look for similarities. There is, we hope that this will eventually enable data depositories so that people can combine their data. There's actually a new effort called Epilepsy.Science that's funded by the NIH that is focused on allowing researchers to compare their own data sets with others, bringing them together, not physically, but allowing researchers to access those data. And having common data elements is critical for understanding how to combine those findings. And then also ultimately helping to align preclinical data with the clinical measures to enhance that translatability. We want to be able to understand the biology of what happens when a SUDEP happens. We can model some of that in our preclinical work, but we have to make sure that we're measuring the right things. So hopefully this will help enable that. So I want to just thank our steering committee and our working group members and of course our sponsor for the hard work that it took in the debate to come up with these common data elements. I want to encourage our research community to use them. We do have materials on our website, and we're always happy to answer any questions. So thank you.
We've got some time for discussion, and there are microphones around the room. I'll just kick off with one for Laura W. And just because it's so exciting to the advocacy community to have this national plan, and I think we can all lend our voices to this. I know we can. If you were to distill down to one step that people should take from any side, advocacy, family, researcher, clinician, what would that step or maybe two steps be?
Yeah, definitely. We need to continue to get co-sponsors on the bill. Again, we've seen good momentum the last few months, but we need to have more. So, and again, we try to make it very simple, that QR code, or I can come up to me after and I can get you connected to that action alert. That's a very simple way to do it. If you want to take, a little bit more extensive outreach, we can support you. If you actually want to schedule a meeting with your congressional office, we're happy to support that too. But on the bill side, getting more co-sponsors is really our priority right now. Moving into next year, Congress works on a 2-year cycle. Moving into next year, it's a midterm election year, come summer, especially maybe even spring, legislative activity is really going to slow down. So we have a, window of opportunity in the next few months to continue to get that support up. Sometimes bills still go through regular order in Congress, like through committee to the floor, et cetera. Other times, they can simply attach a bill to a bigger piece of legislation that has to go through Congress. So we're looking for all of those opportunities, but really having those co-sponsors up is our priority right now. Yeah.
So I just want to add something just from my personal experience in the past 6 months. I was able, I reach out to congresswomen in my district. I reach out to the senators. I did the email, but also I did the phone call and I left the voicemail, and I got actually answers from them. One of them signed. We're still working on the others, but they really need to hear from us, the community, the parents, the people who experience it, and share your stories because they are very powerful.
Thank you so much. Hearing that a new definition of SUDEP might be coming down the pipes is enormously exciting. I'm wondering if you can tell us anything about the process for generating it and whether or not it's likely to be another diagnosis of exclusion, or whether this is going to be something with a bit more affirmatively said about what SUDEP is as opposed to what it is not.
So because it's not completed, I can't give full information. What I can say,
not because it's a secret as much as
not
just
because
we
secret
are
is just
ready to
because
share
it's not fully formed entity, not because we're hiding things. Yeah.
Right.
As you know, the definition of SUDEP has been evolving from kind of the early ones by Anagers and by Lena Nashef, 96, 97, and was kind of calibrated in 2012 with the unified definition. And part of that, these changing definitions, comes from increases in knowledge in the space and trying to address, as Dr. Donner has mentioned before, some of these subtleties, like, is this SUDEP? Well, if it's an unexplained death, but you also had heart disease, for example. And so in the last definition, we created a new category called SUDEP Plus. To cover those kind of circumstances. So in the newer definition, again, working to refine further what we addressed in the first session, the whole patient picture, right? So what are contributions of comorbid conditions, what are other considerations from circumstances of death, but also helping to incorporate some of the other things we've been talking about, including how we investigate death and classify death. So again, not yet a completed work, but is still in progress and hopes to unify some of the things that have still been questions, based on more recent work from the last definition to now.
Hugely exciting. Thank you so much.
Thanks for your interest.
Person.
This is a question addressing the last talk. Really interesting, and looking at all these different CDs. It seems, I guess I'm just wondering what role you think AI might play in starting to untangle some of this data. And I would hope that you're adopting a situation where no data point is too insignificant, because the attraction around AI, of course, is that your eye sees a certain linear, very direct approach. There may be some different situations, underlying conditions, and so on, that might be a little bit different in terms of a risk factor for SUDEP. So I'm just wondering if you're going to be adopting any of those technologies.
That's a great question, and it's an exciting time, I think, for researchers to be able to use these kinds of tools. Having a standardized data structure will be critical for doing that, to enabling these AI technologies. I agree. We were already seeing it being used in some of the clinical work that's being done, because the algorithms that read EEGs and can look for patterns are so much more powerful than the human eye, and certainly faster. So making sure that we do have a solid set, and also an evolving set. We know that we're going to have to evolve these common data elements to keep that moves forward, but then hopefully that can be used within machine learning approaches to expedite the research. Yes.
Great. One just quick comment about that as well, because I think it also, earlier in one of the other presentations, there was something mentioned. The situation was SUDEP physicians don't talk about it because they don't know enough about it. It's a pretty vicious cycle, actually, because you don't talk about it because you don't know enough about it. You don't know enough about it because you don't talk about it. And diving deep into the kind of things that you're doing, I would think certainly is going to be very, very helpful.
Can we get the mic? Thank you. Just to circle back to your question about AI. So we've already heard, people are using it in the seizure prediction space. We heard in our first session this morning, Dr. Odom and Dr. Schomer's work about using AI tools to identify contributors to death. And there's actually a session this afternoon that's being led by Dr. Latu on AI specifically. So stay tuned for that.
If we can get the mic on, thank you. I'm just going to read one of the cue card questions. The SUID-SDY case registry already collects SUDEP data in 13 states or jurisdictions. Are you collaborating with the CDC to collect that information?
Is Heather McLeod here?
Introduce yourself.
Yeah, sorry. Heather, please introduce yourself.
Hi, I'm Heather McLeod. I work on the SUID and SDY case registry. And we have a poster later today that you can come and see. And we do collaborate with PAME and CURE. I don't know if I'm answering the question exactly.
It's my question. So I'm from Indiana, and we have both the SUID and SDY case registries. Those are only active in 13 states. 22 separate states have the SUID registry, for whoever mentioned that earlier. But my question is just, we review SUDEPs as they happen within that best practices time frame according to the CDC. And my question was, we're talking about establishing new databases. Well, while those are in progress, are we collaborating to make sure that we're at least, we can make the data from the SDY case registry available, so we at least have some root data, even if it's not all the data we would want?
So kind of relating to what we were talking about with both the definitions as well as kind of data elements, right? Is that kind of what you were asking?
Well, my question basically was that the data that you're searching for, at least for 0 to 17-year-olds in my state, they can review up to age 20.
Sure.
Are you using the data that already exists within the National Fatality Review case system? Are you using that data to, like I said, to just establish like some raw data while you're working on this other database?
Great question, yeah, and that is being used, and in fact, Heather may be able to comment on this more as well, but there have been study programs using data, large data study programs that use data, including data from SDY. And in fact, there's a whole research grant campaign right now directed by Cure Epilepsy that involves using large data sets such as those in the Center for SUDEP Research, the North American SUDEP Registry, the Sudden Death and the Young Registry, and combining data from those big places to try and get as much information as we can to make more reasonable statements. So absolutely, that data is crucial and is being used.
I'm just want to put in a plug for that as well, and sort of channeling my inner Vicki Whittemore, who would say there are biosamples available, and researchers should be looking for them, using them. It is an underutilized resource that is available for researchers to study the biology of these people, of those who are in this registry. So I'm happy to share information on that. I'm sure Vicki would be as well. Happy to pass along names. But it's an amazing resource. We need to grow it, I think, as part of the national plan, to really get a handle on SUDEP in our nation.
I'll just jump in with one of the cards. There's a family with us today, and I think hopefully it's okay to. Lou, do you want to speak to this? I've got your card, but you go ahead.
Well, yes, but I was just going to give a quick update to the panel that talked about state legislative policy efforts. So my wife and I are the authors of a bill that's going to be introduced in January in Ohio, concurrently in both the House and the Senate. And this is a little bit different strategy than our first effort, which was 2023. In January of 2024, breezed through the Ohio House unanimously by a 91-0 vote, and then it stalled in the Senate. It never even got a hearing. So this time around, we used the PAME toolkit. We incorporated help from Dominique and Allison, and we tweaked the language a little bit, and we removed the word shall and replaced it with the word may. So it's no longer a mandate, it's simply a strong suggestion. And this is, one of you said you need to be persistent, so you can imagine how soul-crushing that might have been when it stalled in the Senate and didn't even get a hearing. But you got to pick yourself up, dust yourself off, and just keep at it and make sure you have the right legislative champions and make sure it's a bipartisan effort. So thank you for your help and all that. So then, yeah, to the card that I wrote, you just want to read it and, okay.
Sure. I'm just going to synopsize it a little bit, but Lou's family has been affected by epilepsy with all three children, and they tragically lost their daughter to SUDEP in 2022. And I've heard Lou say this before, and it's really compelling. He estimates there was probably 70 to 80 opportunities over the 26 years of treatment where a SUDEP conversation could have taken place. And just kind of the question being, does the panel agree that there's a flaw in the system if that many opportunities are passed up? And maybe I'll direct this to my friend Elizabeth. it's a little bit provocative, but if you were to say, what variable or incentive could help to change that dynamic, and I know there are many, if you could point out one or two items that you would think you could really move that needle.
And we talked about this a little bit this morning as well. We've tried to understand why healthcare practitioners don't talk to families about this risk. What's different about epilepsy than, let's say, people talking about risk in other diseases that carry a risk of sudden death, if it's like heart disease or different conditions? It's hard to get at that particularly. I think some of it is a little bit what Lisa was talking about earlier this morning around epilepsy care and neurology care tends to be quite siloed, and practitioners really only want to talk about the seizures, and then, we're not talking about mental health conditions. We're not talking about some of the other aspects of the disease that really need to be addressed. So that's one part of it. Something that's come out of studies that a few of us have done together collaboratively through the Child Neurology Foundation, the American Academy of Neurology, asking neurologists why you don't talk about SUDEP. They say they're concerned about the impact that's going to have either on the person living with epilepsy or the family caregivers. That's going to increase anxiety or worry. In fact, there are some other studies that have demonstrated that it doesn't increase anxiety or worry, and even there was at least one paper I can think of that actually showed that for a kind of cohort of like young adults, I believe it was, that it didn't even change their behavior even in a positive way, which suggested to me that they weren't actually getting the right message, and that we really need to think about what messaging we're even delivering if we're talking about SUDEP. And so it's this one thing is this worry about anxiety, but there's no real evidence that that's the case. And my answer to that is usually that, in fact, people who have epilepsy or care for people with epilepsy are already worried that something bad is going to happen. So even you can have a conversation that might be reassuring because you bring it out in the open and you can have a good talk about it and talk about ways to reduce risk. And then the other big factor is lack of knowledge. And as you said, though, sir, you don't know, so you don't talk about it, and then you don't talk about it, so you don't know. And all I can say is through all the initiatives that we've been talking about here all day, we are trying really, really hard to get people to know more about mortality risks so they feel comfortable talking about it. And I think that goes for the legislative things you're doing as well. Whether you're able to say you have to talk, you have to do this or you can do this, I think even just having a bill, having people talk about it in your legislature, in your Senate or whatever, brings awareness.
Thank you for that take on that. And again, it was my family's journey can't be an outlier. There's got to be more of us out there. But just wanted to drive home the point to the medical community. 26 years, 3 kids, at least twice yearly visits for each kid, multiple 5 to 7 day stays in the epilepsy monitoring unit at the Cleveland Clinic Foundation, one of the best healthcare organizations in the world. So how do we hear about SUDEP for the very first time a week after our daughter's funeral? That there's a flaw there's a communication gap that exists. And so that's why we have these legislative efforts going on in Ohio and other states as well. Thank you for listening.
I agree with you, there is a gap.
Yeah, I agree, and I also want to applaud you for your advocacy and for your perseverance with, that old, it didn't succeed the first time, but I'm going to go back and it's important enough, and that's something we all need to do, is to persevere to get the message out.
I just have a really quick question.
Hi.
Hi. I live and work in California, and I'm kind of saddened by the fact that our biggest state in the union hasn't passed anything meaningful yet. Do you have a way or a listing of the legislation that you're planning or that could be on the horizon for individual states for people who want to get involved with this?
Yes, well, Dominique was about to say something anyway, so she can probably tackle that with California.
So for the California question, the Epilepsy Foundation in California, they are looking at seizure detection device legislation, which does have a SUDEP component, asking the Department of Health to establish an awareness campaign, as well as to let individuals, educate them about the device and them having access to that. And then to also kind of, expand on what Lou was saying about the Ohio bill. In lieu of changing the shall to may, we are asking the Department of Health to establish a post-diagnosed education and follow a 6-month follow-up program if someone receives a diagnosis. So they may not get it at that first doctor's appointment, but in that follow-up education, they should be having those conversations about SUDEP.
Yeah, so we'd love to link you to the efforts and, have you be part of that and help improve, and that'd be great.
Okay, I know we could keep going because this is a great discussion, but we are going to break for lunch. And just to plug this science networking lunch is in Ballroom A, and everyone else is welcome to stay here, eat in here in Ballroom E. So, yep, bathrooms are down the escalators, 1 floor down, and try to meet somebody new. Thanks to all our panelists.